Hello, everybody. This is Lisa Rowling, and today I want to walk you through type 1 diabetes in the 12 to 18-year-old. The objectives for today is that the learner will understand how type 1 diabetes affects the pathophysiology of various body systems. The learner will understand how type 1 diabetes affects the developmental milestones of the 12 to 18-year-old. The learner will understand the cultural, ethnic, and gender considerations for the 12 to 18-year-old with type 1 diabetes. The learner will also understand the modifiable and non-modifiable factors that impact the 12 to 18-year-old. The learner will understand the nursing interventions for the 12 to 18-year-old with type 1 diabetes. And finally, the learner will understand how technology is used to help 12 to 18-year-olds manage their type 1 diabetes. So, in order to understand what happens with type 1 diabetes, it's important to understand just normal pathophysiology with glucose regulation. And the big question here is, how does food get turned into energy? When you eat carbohydrate containing food, that food is going to go to your gut, your small intestine, and from the small intestine is where glucose gets absorbed into your bloodstream. So you eat, the food goes down, goes through your small intestine, converted into sugar. Sugar enters the bloodstream. Now, as the glucose levels rise in the blood, this is going to trigger an insulin release from the pancreatic beta cells. But it's also important to remember that food isn't the only thing that's going to trigger a rise in blood sugar. We know that hormonal responses and stress and different factors can affect this as well. So basically, your pancreas is going to drip off a little bit of insulin all day long to hold those blood glucose levels within a normal range. But particularly in response to food, you're going to get a quicker burst of insulin to help with the glucose regulation, and that's what that negative feedback loop is all about. So insulin's job is to help move glucose into the cells, and inside the cells is where the Krebs cycle takes place, and ATP gets produced, and ATP is what gives our bodies energy. So, what is type 1 diabetes? Type 1 diabetes is an endocrine and an autoimmune disorder. And I do want to stress the autoimmunity part of this because there's a lot of confusion out there between type 1 and type 2, and I hope to clarify that after this slide. So, what happens with type 1 diabetes is the body's immune system destroys the pancreatic beta cells, and this leaves the body completely insulin deficient. Now, I do realize that over time with type 2 diabetes, a patient can go through beta cell burnout, is what we call it, and they can become insulin deficient as well. But a patient can become insulin deficient and depend on insulin as a type 2, but that does not make them a type 1 diabetic. The difference is this: there is an immune mediated response that produces autoantibodies that can be detected in the blood. And people that have type 2 diabetes do not produce the same autoantibodies that people with type 1 have. Now, the reason I bring this up is because there's a lot of physicians that will tell a patient if they have type 2 diabetes that once they go on insulin that they're a type 1, and that just is not the case. So, exogenous insulin is required to prevent hyperglycemia and to sustain life with someone that has type 1 diabetes. This can be the case with type 2 as well, but it is always the case with type 1. So, the autoantibodies that are there that are related to type 1 are your GAD, your glutamic acid decarboxylase antibodies, your tyrosine phosphates, and there's AA2 and AA2 beta. So there's two under the tyrosine phosphates, and then zinc transporter 8 or the ZNT8. And the one I see used the most for the detection of type 1, if you've got someone, let's say as an adult, that comes in and they can't decide if they're type 1 or type 2, a lot of times they'll go ahead and do that GAD antibody test. And keep in mind that these are non-modifiable factors for the type 1 diabetic. So the symptoms of type 1 diabetes include extreme hyperglycemia. Now, you may not see a 12 to 18-year-old come in with a blood sugar of 544, and I hope that you don't, but it will be elevated. You're also going to see polydipsia, polyphagia, polyuria, rapid weight loss, fatigue and lethargy, and all this stuff is usually leading to DKA or diabetic ketoacidosis, where you will find ketones in the blood as well as in the urine. I do want to share with you some information about the insulin effect on weight. We know that insulin is a growth hormone. And rapid weight loss is also a sign of type 1 diabetes. And what happens is that when the body cannot get properly fueled from glucose, the body will start to catabolize fat stores. And that's what leads to the progression of this rapid weight loss. But insulin is used to help put weight back on adolescents diagnosed with type 1. And nothing really drove this point home for me like these pictures. So this is a patient before insulin, and these were taken when insulin was first discovered back in the 1920s. And then after 5 months of insulin therapy, you can see that the weight was put back on. Now, what gets interesting about this is when young girls figure out that insulin will make them gain weight, a lot of times they will skip doses in order to lose weight. And this can be very dangerous because it can lead to DKA. So now we're going to move on to the various body systems, and we're going to start with the hemopoietic system. And the number one disease that we see diagnosed in the type 1 diabetes population is B12 deficiency, or commonly called as pernicious anemia. We know that pernicious anemia can lead to a very sore tongue. That's why that picture is there. But what happens is the autoimmune destruction of intrinsic factor can happen in a type 1 diabetic, and that intrinsic factor can lead to atrophy of the gastric mucosa and glands and leave the patient with type 1 diabetes unable to absorb B12. And another anemia that we'll see in this population is sickle cell. Now, we don't see a lot of patients from Africa, South Central America, Caribbean, or the Middle East having type 1 diabetes in the 12 to 18 population, but there are some. And so, with a patient that does present with sickle cell anemia and diabetes, we have to think of other methods of assessment for glucose control because the American Diabetes Association has identified that anemia is an interfering factor for hemoglobin A1C results. Now, moving on to the cardiovascular um, concerns that we have, the American Diabetes Association recommends an LDL goal of less than 100. And if a patient between the ages of 12 and 18 has an LDL of 160 or above, or if they're 130 and there is another cardiovascular risk factor there, then the ADA recommends that these patients go ahead and get started on a statin. However, the long-term efficacy and effects of statin therapy in the pediatric patient has not yet been determined. So I kind of find it surprising that the ADA makes this recommendation, but it is indeed there. Then when we move on to blood pressure and weight goals for the type 1 diabetic patient between the ages of 18, between the ages of 12 and 18, we're looking at percentile goals for weight, and this is based on age and sex related chart. And so the diastolic and systolic pressures that are greater than the 90th percentile, based on those charts, the recommendation by the ADA at that point is to go ahead and start the patient on an ACE inhibitor or an ARB. So now we're moving on to respiratory function. And when we think about the most common chronic pulmonary disease that affects children in this age group, we have to think about asthma. There's a lot of kids that have asthma. And we also have to think about patients that have cystic fibrosis. Now, type 1 diabetes in this age group doesn't necessarily mean, unless they have symptoms, that they need to be tested for CF. However, a patient that does have cystic fibrosis, the recommendation is that they be checked annually for diabetes. Cystic fibrosis basically blocks the airways and ducts and passages of the lungs and of the pancreas. And so, if the pancreatic duct cannot secrete insulin, then that's what can lead to type 1 diabetes. And so we call that cystic fibrosis related diabetes, and it is recommended that these patients be tested annually for type 1 diabetes. Now, DKA is on this slide because DKA is going to change respiratory, not only in the rate, but how the patient is breathing. That rapid panting that we call Kussmaul respirations is what you're going to see. And what's happening there is the body is trying to eliminate acid, and it does that by exhaling more carbon dioxide. And so that's where you're going to see the Kussmaul respirations. And then we also have to consider smoking in this age group. A study that I looked at showed that kids between the ages of 15 and 18 typically is the age that smoking begins. And so the ADA does recommend that smoking cessation counseling be part of the diabetes care plan. So now we're going to move on to urinary function. And when the blood glucose reaches 180 or higher, that's when we start seeing glucose spilling over into the urine. And what I find very interesting is that if you look at the history of diabetes, the word diabetes means siphon. And so you're going to see patients that are going to be urinating a lot, that polyuria is part of that diagnostic symptomology that you're going to see. But early researchers actually learned about diabetes because they would notice that ants were flocking to the urine of some patients because that urine was sweeter. We do know that sodium and potassium is regulated via the sympathetic nervous system, and that changes in the glomerular filtration rate either increases or decreases with sodium excretion. But lack of insulin actually impairs potassium transport into the cells. It causes the potassium to shift out of the cells. And these shifts can actually cause a shift in pH, and that can lead to diabetic ketoacidosis. So we learned from the earlier slide that a shift in potassium and sodium can lead to electrolyte imbalances that can shift the pH, and that can lead to diabetic ketoacidosis or DKA. And DKA can be caused from trauma, infections, and insulin omissions. So you may be wondering, well, why would anybody omit their insulin? But in the 12 to 18-year-old, there's a couple of things that happen. One, sometimes patients just get angry that they have diabetes and they don't want to deal with it, so they will skip their insulin doses. But where we typically see this most commonly is with girls, and girls are at a higher, they have a higher incidence of DKA more so than boys, simply because when they figure out that insulin will cause them to gain weight, a lot of times they will omit those insulin doses for that very reason. And when you see trauma, infection, or insulin omissions, this can trigger counter-regulatory hormones such as catecholamines, glucagon, cortisol, and growth hormone. And these hormones elevate blood sugars, and these are non modifiable factors that will impact the patient with type 1 diabetes. So we were talking on the previous slide about electrolyte imbalances and shifts in pH that can lead to DKA, but it's important to remember that when a patient comes in with hyperglycemia, the cells are in a hypertonic state, and that's going to cause the fluids to shift from the intracellular to the intravascular space, and that's what causes dehydration. Now, DKA is more common in females than they are in men, but when these patients come in, you're going to see them having Kussmaul respirations. They may have fruity odor in their breath, a cough, nausea, vomiting, and abdominal pain, which, depending on developmental age, I may refer to as a toxic tummy ache, headache, sleepiness, and confusion, fatigue, lethargy, muscle weakness, arrhythmia, increased heart rate, and progressive loss of consciousness that can lead to coma, hypotension, dysrhythmias, and shock. Now, one of the primary nursing considerations for a 12 to 18-year-old when they come in with DKA is the potential for cerebral edema. This gets really tricky when you consider that one of the primary things that we're trying to correct is the dehydration. And so careful nursing assessment for cerebral edema is important because it is the number one cause of mortality for the child between the ages of 12 to 18 that comes in with type 1 diabetes and DKA. So now we're moving on to the reproductive system. And kids between the ages of 12 to 18 are going through puberty. They've got their hormones that are starting to circulate, and they may engage in risk taking behavior, including sexual exploration, unprotected sex, and the conception misconceptions that are there is related to a study by Jesper and his colleagues in 2011, who stated that girls with type 1 diabetes may engage in unprotected sex because they mistakenly believe that they will have trouble conceiving due to their diabetes diagnosis. And of course, this can lead to unplanned pregnancies, early pregnancy loss, obstetrical complications. And so, preconception counseling is something that's necessary. With males, they can have delayed puberty, due to delayed spermatogenesis. They can also experience erectile dysfunction depending on length of time that they've had diabetes and the amount of control that they've had during their time with their diagnosis. And females can also have delayed puberty, delayed menarche, menstrual irregularities, polycystic ovarian syndrome, and we do know that increased A1Cs and increased insulin doses can lead to increased cycle duration and variability. So I mentioned earlier that type 1 diabetes is an endocrine disorder, and the word endocrine actually means to secrete directly into the bloodstream. But the thing that's not being secreted in the case with type 1 diabetes is the insulin. You can see in this picture that the blue dots are representative of glucose, and the green dots are representative of insulin. And so you've got an overabundance of glucose in the system because the insulin is not properly being excreted. So insulin is actually manufactured in the pancreatic beta cells located in the islets of Langerhans. And the endocrine system actually runs off negative feedback loops. And this means that hormones are going to rise or fall due to biochemical processes. And keep in mind that insulin is produced in the beta cells of the pancreas. Amylin, somatostatin, glucagon, and ghrelin are actually produced in the alpha and delta cells of the pancreas. And those hormones are also responsible for regulation in glucose in the bloodstream. So now we've made it to the gastrointestinal system, and one of the most common disorders that we see is just plain old gastritis or gastroenteritis that's combined with nausea and vomiting. The problem with type 1 diabetes is this can very quickly progress to DKA, so these patients need to be monitored very carefully. Cummins found in 2014 that pancreatic exocrine insufficiency is found in 50% of patients with type 1 diabetes. And because insulin has a trophic effect on pancreatic tissue, the lack of insulin that we see with type 1 can lead to pancreatic atrophy, and that's what leads to PEI. And the symptomology there is loose bowel movements, abdominal discomfort, and flatulence. And PEI can also lead to fat malabsorption, and that fat malabsorption does include vitamin D, which can, if you can't absorb it, can lead to osteoporosis. The symptoms that are there can also overlap with celiac disease. Celiac disease is more common in people that have type 1, and the ADA does recommend that people with type 1 be tested for celiac disease. Celiac disease is an autoimmune disorder, just like type 1 diabetes. The autoimmune immunity actually affects the intestinal enzymes that break down gluten, and so these patients are put on a gluten free diet for life. Another common thing we see with type 1 diabetes is gastroparesis, and that is autonomic neuropathy of the vagal nerve, and this is going to slow gastric emptying. So these patients will eat, the food will sit in their stomach, and then it will dump suddenly into the small intestine. And the big nursing consideration here is when to give the insulin. If you give insulin before a meal and a patient has gastroparesis, they can actually experience hypoglycemia before that meal is actually absorbed and converted into glucose. So what we recommend with gastroparesis is that insulin be given after the meal versus before the meal. So now we're moving on to musculoskeletal system. And I mentioned before that PEI can lead to vitamin D deficiency, and we know that vitamin D deficiency can lead to osteoporosis. Now, we typically don't see this in this age group of 12 and 18-year-old, but it's definitely a consideration. But one of the things that we do think about in this age group is soda pop consumption. And one of the studies that found showed that 70% of adolescent boys and 60% of adolescent girls report drinking sweetened beverages daily. 67% of those beverages are soft drinks. And another study showed that 20% of all adolescents consume a minimum of 4 soda pop servings a day. And so when we're doing any kind of dietary counseling with these patients, we need to inform them of what those soda pops can do. And that's regardless of whether they're diet or whether they're regular soda pops that can lead to the vitamin D deficiency in type 1 diabetes. Neural considerations for the 12 to 18-year-old with type 1 diabetes includes traumatic brain injuries, and there's a couple of reasons for this. This is the age group when these patients start driving, so there's a lot of driving concerns, but a lot of these patients do participate in contact sports like football and soccer. So concussions, cerebral contusions, and skull fractures are something that we can see in this population. Hypoglycemia is very, very important because of driving concerns. A patient can have seizures when they have low blood sugar, and depending on length of time that they've had diabetes, one of the autonomic neuropathies that can occur is hypoglycemia unawareness, and so that can set up a very dangerous situation when we put a teenager behind the wheel of a car. And then sensory malfunctions that we see is retinopathy and neuropathy, which has been very well studied. And I do have a picture here of a normal retina compared to one that has hemorrhaging, aneurysms, and exudate on the retina. And we typically don't see retinopathy and neuropathy in prepubertal teenagers, and we don't see it in patients that had type 1 diabetes of 1 to 2 years. But after 5 to 10 years of type 1, we can see that these type of sensory malfunctions can occur. So now we're going to shift gears and we're going to talk about the developmental milestones for the 12 to 18-year-old. And these include puberty. They're going through a lot of bodily changes. They're developing a strong sense of identity. Their peers are very important to them. How they fit in with their peers is very important. Body image is huge, especially with girls. And Um, in a study in 2005, Frank actually found that 10% of girls with diabetes have met the diagnostic criteria for subclinical eating disorders, and depression in type 1 adolescent girls is twice that of boys in the same age group. And I think a lot of this has to do with body image issues that are out there for this population of teenage girls. Risk taking behaviors can include smoking, drinking, drugs, and sexual exploration. And then that independence. We're trying to transition these patients from the parents caring for their diabetes to self care. However, depending on where they're at with their developmental progress, we don't want to push that and it happen prematurely because that can lead to a lot of conflict in the family. Additional non-modifiable factors of the type 1 diabetic patient between the ages of 12 and 18 is family stress and emotional mental stress. And the reason this is there, and I do realize that stress can be modified as far as coping mechanisms, but if a child is in a family situation that is proving to be stressful for them, they have no control over that. So I did list that as a non modifiable factor. And then illness, injury, trauma, and infection can definitely impact hyperglycemia. So those additionally are non-modifiable factors for the type 1 diabetic patient. So cultural, ethnic, and gender considerations. When we think about type 1 diabetes in the 12 to 18-year-old, we're dealing with mostly a Caucasian population. And that's not to say that type 1 diabetes does not occur in other cultures, it does, but the highest prevalence is among non-Hispanic whites. Now we have to consider generational beliefs. These may be folk remedies or things that are passed down from generation to generation, along with religious beliefs, which may include fasting or feasting days, kosher, vegetarian, or vegan diets could also be listed on there. We also have to consider the socioeconomic status of parents and then food preferences. You know, we all as parents want our kids to be eating like this, but a lot of times kids between the ages of 12 and 18 want to be eating more of this. And that can lead to family conflict, and it leaves us wondering, well, what can these kids eat? So health literacy is huge, especially when it comes to dietary counseling. We can't just throw books and brochures at parents and children and hope for the best for them. We do have to consider the health literacy that is there. And then I mentioned earlier about vegetarian and vegan diets. And so these all need to be taken into consideration when we're considering interactions that we can have with the type 1 diabetic patient between the ages of 12 and 18. Here is an overview of non modifiable factors that we've talked about so far. The autoantibodies that are present, stress, the different counter-regulatory hormones that can occur and lead to hyperglycemia, race, family, and age. These are all non-modifiable things that happen with type 1 diabetes. So now I want to move on to what we can do with diabetes and look at the modifiable factors of type 1. And it gets even busier because we're looking at things like diet and exercise and body weight, the prevention of long term complications, insulin delivery systems, and then coping skills. And all of these can be modifiable factors for the 12 to 18-year-old with type 1 diabetes. Nursing care interventions can either be primary, secondary, or tertiary, and primary interventions protect or prevent developing a health condition. Secondary interventions are those interventions that happen after diagnosis, and tertiary interventions are interventions that help people manage complicated long term health problems like type 1 diabetes. As I said on the previous slide, primary interventions are those interventions that protect or prevent a health condition from happening. And with type 1 diabetes, there's many theories and studies. There's the avoidance of cow's milk, breastfeeding versus formula feeding, no gluten containing foods prior to 3 months of age, and then vitamin D supplementation. These are all things that have been looked at, but there's been nothing that's been really conclusive that we can put our finger on. So there is no way to prevent type 1 diabetes. So what we have to focus on as nurses is the secondary and tertiary interventions that we can deliver on to help patients with type 1 diabetes. Secondary interventions are interventions that happen right after diagnosis, and what we really want to focus on are diabetes survival skills for both the parents and the child with diabetes. These include glucose and ketone monitoring, insulin therapy. They need to understand multiple daily injections are going to be necessary, and they don't just need to understand how to give the insulin, they need to understand the insulin action as well as rotation of sites. Meal planning, we do want to refer these patients to a registered dietitian, but while they're waiting to be seen by a registered dietitian, going over a simple plate method with them can be very helpful until they can get in and learn how to count carbohydrates. And hypoglycemia management is very important. We want the parents and the child to understand how to prevent, how to recognize, and how to treat hypoglycemia. Tertiary interventions help people manage complicated long term health problems. So, when it comes to type 1 diabetes, all interventions, whether they're secondary or tertiary, need to be culturally sensitive and developmentally appropriate. So I pulled tertiary interventions for the type 1 diabetes patient between the ages of 12 and 13 from the American Association of Diabetes Educators, and they have 7 self care behaviors that we really want patients to focus on for a lifetime. And these revolve around healthy eating, which includes carbohydrate counting, being active, and the ADA recommends 30 minutes of activity 3 to 5 days a week. So it may be an important conversation to have about possible sports or just whatever the patient is interested in, and we have to meet them on their level. Monitoring blood glucose. Yes, they need to know how to use a glucometer, but they also need to know what target ranges to shoot for. And the ADA recommends a blood sugar of 90 to 130 before meals and 90 to 150 at bedtime. We want that HbA1c to be less than 7.5%, and we would like for those ketones to be negative. We need to have the patient and their family understand the importance of taking medication. And so, for this population, it is going to be insulin injections. And they need to understand how to calculate insulin injections around carbohydrate and also how to calculate for a correction dose should the blood sugars be high. They need to understand the importance of rotating the injection sites, and they do need to understand insulin action, duration, peaking times so that they don't get those insulins mixed up. They also need problem solving skills such as what to do for sick days and how to handle hypo and hyperglycemia. They need to develop some healthy coping skills, and how to deal with diabetes at school is huge for this population of patients. The American Diabetes Association actually has care plans that can be printed and filled out with the healthcare provider and taken to the school. But how they deal with diabetes at school is a huge factor. And then reducing risk. And when I talk about reducing risk, I'm not necessarily talking about risky behaviors. I'm talking about the risk for complications. The diabetes complication and control trial showed that tight glycemic control can help reduce risk. And so they do recommend a healthcare provider visit every 3 months for an A1C, an eye and foot exam annually, dental visits every 6 months, and then that lipid panel once a year. So, other tertiary interventions that the nurse can do revolve around diabetes self management education. So, some additional topics to discuss with adolescents include transition care planning from parent to child, the personal meaning of diabetes. These patients are at that developmental age of developing a sense of self identity. So, where does diabetes fit in with that picture? And then determining roles and responsibility between parent and child. How are they going to handle social situations in dating? When all their friends are out eating pizza, how are they going to handle that situation? Who and when to tell about diabetes? And then we discussed earlier the driving considerations. And then sex and preconception counseling also needs to take place along with drug, alcohol, and smoking. Needs to be other topics for diabetes self management. And then what is this child going to do once they leave their parents' house? Are they going to plan for college? Are they going to plan for a career? These are all topics that will affect diabetes care in the 12 to 18-year-old. And then I put this slide on here about why intervene. I'm a why kind of person. And basically, what we're trying to do is prevent long term complications, such as periodontal disease. We don't want these kids losing their teeth, retinopathy and blindness that can occur, nephropathy and neuropathy, and then cardiovascular disease, stroke, and risk. This is why we're intervening, is to prevent these complications. Technology is very exciting in the role it plays with diabetes care. And so I'm going to talk about less technical and more technical, and then I'm going to end going back to a less technical thing. So we're going to start with insulin delivery systems, and these have really gotten robust over the past few years. We started out with vial and syringe. A lot of patients that are in the 12 to 18-year-old, they don't use vial and syringe. They typically use insulin pens or insulin pumps. So we're going to talk about insulin pumps in our next slide. Continuous subcutaneous insulin infusion, also otherwise known as insulin pumps. There's four major brands out there. Medtronic has a MiniMed pump, Accucheck has the Spirit pump, Animas has the Vive, and Omnipod has a tubeless pump. And so pumps basically run off of a reservoir. You can see on the Accucheck Spirit pump there that the little syringe, that's what we call a reservoir. They fill up 3 days worth of insulin, and that insulin will drip off via a basal rate. And then when the patient eats, they will calculate how many carbohydrates they are consuming. The pumps have an insulin to carbohydrate ratio set up in them. So they put in the amount of carbs they're having. They will also put in the blood sugars, and the pump will calculate an insulin dose based on that information. One of the misconceptions about insulin pumps is that they're surgically implanted, and that is not the case. These run off of an infusion set that the patient will change out every 3 days. And another misconception is that the patient will no longer have to do blood sugar sticks or finger sticks, and that is also untrue. They have to do more finger sticks in order to keep up with the blood sugars. But the nice thing about pumps is that different basal rates can be set for different activities throughout the day. So if there's a time that they get higher or a time that they're lower, they can either turn the rate up or turn the rate down. Another great benefit of insulin pump technology is that if the patient has hypoglycemia, they can stop the pump temporarily and treat the hypoglycemia and then turn the pump on. And it just allows for smoother blood glucose levels throughout the day when they do that. So now we're going to move on to a little bit more technologically advancement, and that's with continuous glucose monitoring devices, which are CGMSs. And so CGMSs operate off of three different things. They have a sensor wire that sits underneath the skin. Sitting on top of that sensor wire is a transmitter. Now, this is an insertion device. This is just showing you how the sensor wire gets inserted underneath the skin. But the third component to this is the receiver. And so the sensor is actually sensing the glucose. Now, this is not blood glucose, it senses interstitial glucose readings. And it does this every 5 minutes and plots that reading onto the graph. And so you can see on the display on the receiver that there's an upper limit and a lower limit. What's nice about these devices is that if the patient's blood sugar goes above the limit for high, they're going to get an alarm, or below the limit, they're going to alarm. And so that's really nice at night if they have nocturnal hypoglycemia to be alarmed during the night. And once they insert the sensor, it can be worn for 7 days. And this is typically what it looks like on the body. And what's really exciting about the Dexcom brand, which is an independent maker of a CGMS device, is that last month they came out with Share software. And what that software is, it's an iPhone app, and the information that's on the device can actually transmit the information to this app. So let's say that you're a parent and you're at work and your child is at school. If the child is having trouble with his glucose, you can actually get on your Share app on your phone and see what's going on with the glucose throughout the day. So I love the new technology that's there with CGMS devices. So I mentioned earlier that the CGMS devices have receivers. However, some of the pumps that are available, including the Medtronic and the Animas Vibe, actually the pump is serving as the receiver. So you're going to see on the screen of the pump the CGMS readings that are there. And this is optional because these pumps that are available, you can get them with or without this technology built in. And of course, the more technology you get with your pump, the more expensive the price is. And other technology that is available is cell phone apps. And there's numerous cell phone apps that are out there. There's carbohydrate counters, there's insulin bolus dosing calculators that are out there. There's just all kinds of cell phone apps that can help the patient with type 1 diabetes. I want to share with you some future technology that's not yet FDA approved. And I'm going to start with the Apple app and biometric watch. Now, I know that some of these are already available with pedometers and heart rate monitors, but for glucose testing, they are not available yet. But this is on the horizon, and I think this is probably going to be one that we're going to see hit the market sooner than later. Another thing that's out there that I've seen is glucose sensing contact lens. I really think that's a cool and novel idea. One of the things that is also underway is the Bionic Pancreas Project. So, if you think back to negative feedback loops with diabetes, if your blood sugar drops, glucagon is going to get released, and glucagon is stored up sugar. If your blood sugar is elevated, insulin gets released. And so, based on an iPhone platform, you've got a glucose sensor that's going to sense the blood sugars, and if it gets low, then the glucagon pump is going to kick in, and if the blood sugars get high, the insulin pump will kick in. And so that is all based on algorithmic technology on this iPhone app. The only problem is this. I wear a pump. I don't want to wear all this. I wear a pump. I also wear a sensor. I don't want to wear two pumps. And so I'm hoping that the technology gets a lot smaller. And what I'd really like to see is a dual chamber pump so that this can be pulled down to one pump, maybe with two different infusion sets. So last but not least, I want to share with you probably the least technical but most helpful thing that a child between the ages of 12 and 18 can have, and that's a diabetes alert dog. These dogs are absolutely awesome. And I do have a friend, and her son has type 1 diabetes. This is Luke, and this is his dog, Reed. He named his dog Reed because he reads his blood sugars. And his mother has shared with me numerous stories about how this dog has awoken them at night and alerted them when Luke's blood sugar is either too high or too low. And they are just precious, so I had to share it with you guys. In conclusion, I want to share with you guys my concept map for type 1 diabetes in the 12 to 18-year-old. In the yellow, you can see the non modifiable factors that we discussed with the autoantibodies, the stress, the hormones, race, family, and age. And then in the pink, you're going to see the modifiable factors, including diet, exercise, body weight, the prevention of long term complications, the various insulin delivery systems, and where things get kind of muddled and cross over is down at the bottom with the coping skills. We know that family situations are non modifiable, but the coping skills and the behavior and attitudes that are there, along with the interactions, those can be modifiable factors. And then the self efficacy that's there with the child becoming more responsible and their own roles and responsibilities in taking care of their type 1 diabetes is there also. And I do realize that this is a very busy slide, but diabetes is a very busy disease as well. So here's my list of references. I appreciate you guys for taking the time to watch my presentation. And again, I've got additional references on this page. And lastly, I just want to give you guys a great big thank you for taking the time to view my presentation. Thank you so much.